வருது சார்.
சவுண்ட் கேக்குதுல?
வருது சார். வருதுங்க சார். சவுண்ட் நல்லா தான் சார் வருது.
இளையராஜா கிளினிக்கா இது ஹாஸ்பிட்டல்? அது
வீடு தான் சார் இது.
வீடு தானே? இல்ல மரம் நிறைய செழிப்பா பழம் காய் பறவை எல்லாம் இருக்கு பின்னாடி மரத்துல.
அது என் பொண்ணு ரூம் சார். என் பொண்ணு ரூம் அது மாதிரி டிசைன் பண்ணிருக்கு சார்.
நல்லதா இருக்கு. மரம் வந்தா செழிப்பு தானே.
மீட்டிங்காக கொஞ்சம் பாரோ பண்ணிருக்கேன் சார் அவங்க.
Good evening, Dr. Tangavelu and others. All the
Good evening, sir. Good evening. Good evening. Same, sir. Login funny and same. Two more minutes, sir. We'll wait for brief details.
ஜெயராஜ் த்ரீன்ல பிரசன்ன வந்து வைல்ட் லைஃப் போட்டோகிராஃபர் த்ரீன்ல நீங்களே ஒரே டைப்ல முடிச்சிங்க போல இருக்குல்ல?
ஆமா சார். அவன் நல்ல போட்டோகிராஃபி ஸ்கில்ஸ், சூப்பர் ஸ்கில்ஸ் சார். அவன் எங்கெங்கயோ ஆப்பிரிக்கா எங்கெங்கயோ போய் போட்டோ எடுத்து வந்திருக்காப்ல சார்.
பார்த்தாலே தெரியுது பிரைட்டா இல்ல ஃபேஸ் பார்த்தாலே.
ஆமா சார். நேஷனல் ஜியோகிராஃபிக்ல ஹஸ் காட் பப்ளிகேஷன் சார், என்ஜிசில.
ஓ அப்படியா?
சார் நல்ல குவைட் எக்ஸ்பீரியன்ஸ்டு போட்டோகிராஃபர், வைல்ட் லைஃப் போட்டோகிராஃபர்.
சார் சும்மாவே அவன் ஓட்டுவான் சார். என்ன நீங்க வேற சொல்றீங்க?
இல்ல உங்க போட்டோ பாத்துருக்கேன், நிறைய ஷேர் பண்ணீங்க எனக்கும் ஞாபகம் இருக்கா?
ஆமா சார். எஸ்பி சார் கால் பண்ணிட்டு வந்தோம்.
Good evening, sir.
Good evening, Janani. Good evening.
Good evening.
Ma'am, good evening, ma'am.
Good evening, Ilayaraja.
Good evening, ma'am.
Anirudh, good luck, Anirudh.
Anirudh, unmute பண்ணிக்கங்க.
Unmute.
Good evening, ma'am. Sorry, ma'am.
Yeah. Good. Hi, Prasanna.
Good evening, madam. Good evening, madam.
The person who's organizing, the person who's moderating, both are our students. Of course, sir is our teacher and the other two are our students.
Good evening, Janani.
Good evening, sir. எப்படி சார் இருக்கீங்க?
Okay.
இங்க யூஎஸ்ல போய் ஹைபர்னேட்டிங்.
Hibernating. Yeah, you can say that.
மனசெல்லாம் இந்தியால இருக்கு இல்ல சார்?
ஆமாமா.
உடல் இங்கே
so many. Yeah, mixed so many pedicons.
சோமசுந்தரம், வணக்கம் சோமசுந்தரம்.
Good evening, sir. Good evening.
Hi, Somasundaram. Good evening.
Madam.
Good evening, Somasundaram, sir.
Namaskaram, sir. Good evening.
Good evening, Soms.
SPS sir வந்துட்டாங்களா?
டைம் ஆயிடுச்சுல. 8 o'clock ஆனவனே. ஒரு 1 minute இருக்கு.
1 minute இருக்கு.
SBS சார் ஜாயின் பண்ணலையா?
நேராஜா வந்துட்டாரு. Sir வந்துட்டாரு.
Good evening, Bala sir.
Good evening, good evening, good evening.
பாலா
Very
good evening.
nice, sir.
நிறைய
Good
புக் இருக்கு பின்னாடி.
அது சும்மா படம் ஒரு மாயை.
மண்டைக்குள்ள இருக்கிறது மண்டைக்கு
எல்லாம் உள்ள இருக்குது.
மாயை.
Bro,
அது ஒரு ஃபால்ஸ் சீலிங் மாதிரி.
Good evening, sir.
Good evening, Somasundaram.
Good evening.
Prasanna.
Good evening, sir.
Nice to see
That's
Professor
fun.
Srinivasan after a long time. Online.
Thank you, sir. Thank you very much.
sir,
சார் நீங்க
good morning.
மணிரத்னம் படம் மாதிரி இருக்கீங்க சார். நிழல் மறைஞ்சிருக்கீங்க.
Morning நினைக்கிறேன் சாருக்கு. சார் என்ன சார் டைம் அங்க? பிரசன்னா ஸ்டார்ட் பண்ணிடுவோம்.
Start பண்ணிடலாமா மேடம்? Okay. At this outset, I welcome you all for this sixth edition of PG curriculum teaching program, a brainchild of Dr. Somasundaram, our IAP president. This program is very unique. Actually, we usually bring one senior pediatrician and one emerging specialist in the field. So we want both of their ideas to get to the PGs, and we discuss in postgraduate exam level. So and month after month we usually see 50 to 100 students joining and benefiting from this. And we have our YouTube channel. In the YouTube channel, a lot of people see it again and again. Some of the sessions have gone beyond the 500, 600 views. So PGs are very benefited from this. So I welcome the coordinator for the program, Dr. SBS sir. And for this month, for the pulmonology topic, we have two stalwarts, one a senior person. I don't think there is any need for introduction to Dr. Thangavel sir. He's a consultant and a medical director in Department of Pediatrics in Mehta's Hospital. And I also welcome my dear friend Dr. Iliraja. Dr. Iliraja is associate professor and he's heading the division of pediatric pulmonology in Ramchandra Medical College. So with this introduction, we'll start the session with Dr. Anirudh Balaji. Dr. Anirudh Balaji is from Kanji Kamakodi Children's Hospital. He readily accepted to present, volunteered to present this case. Anything else, sir? Somasundaram, sir?
Yes, sir. So from on behalf, so from my side, I should thank Dr. SPS sir, who has taken all his time on the last Tuesday of the month to be with us between 8 to 10 p.m. And Dr. Prasanna, who is doing the excellent job of coordinating with the faculty, the Dr. SPS and the Shishya presenter. Every month he starts 1 week after this meeting is over, and he keeps in touch with me to keep the ball rolling every month. And we see to that this webinar is come up in a big way. And as he told, the numbers are increasing day by day on the views as per the YouTube channel. So for this, we have, as Dr. Prasanna told, it's all one person from the specialty side and one who is an senior clinician. So we choose those two people. So last time it was Dr. Sai Leela and Dr. Sundari, and this time Dr. Ilayaraja, who is my co in my DCH, and he's gone to he's now as a pulmonologist, and all the teacher of teachers, Dr. Thangavelu sir, who will be enlightening us on the pulmonology topics. So without much ado, so welcome you, both of you, sir, and Dr. SPS, sir. So we hope this session will be another enriching session for the postgraduates. And I can see a lot of practitioners also logging in because this is going to be some refreshment course for the practitioners also. So welcome all who has joined on board, and over to Prasanna to continue this session. Thank you.
So without wasting much time, we'll start. Sir, can you share the slides, sir?
Sir, SPS, sir, do you want to say anything, sir?
Nothing except that I look forward to learning from Dr. Ilayaraja and Dr. Thangavelu. It's always a pleasure to listen to somebody like Thangavelu on any topic, let it be pulmonology, let it be intensive care, let it be poisoning, let it be emergency medicine, let it be clinical pediatrics. He's such a sane pediatrician, a strong general pediatrician, a vanishing breed today. And he is now joining hands He's joining hands with Ilayaraja, who was our student in KKCTH, who has now established himself as a pulmonologist at SRMC. I look forward to learning from both of them. And with Dr. Srinivasan's presence, the whole thing becomes very exciting for me. Thank you very much.
Thank you, sir. I thank for the opportunity given. What we learned the day before yesterday, we are sharing with you, sir. The first person who learned from any CME is the faculty. So what we learned the last few days, we are going to share with you. And also learn from all of you, sir. Thank you.
Good evening to one and all present here.
Anirudh, you can start presenting.
Good evening to one and all who are present here, my beloved professors and my fellow colleagues. I'm here to present a case in the IAP, CCB, PNSC, PG clinics under the guidance of Dr. Ilayaraja sir and Dr. Thangavelu sir. So here we are going to see a case about Master Y, an 11-month-old male infant who's hailing from Tiruvallur, whose history is given by both mother and father, who is reliable. The chief complaints being failure to gain weight for the past 5 months, fever for 4 days, cough for 4 days, with fast breathing for 2 days in the background of recurrent respiratory tract infections since 6 months of age. Coming to present illness, the child was apparently well till 6 months of age, after which the mother observed suboptimal weight gain in the child following initiation of the complementary feeding. At 6 months of age, the child was admitted for the similar complaints and was found to weigh 5 kgs and has failed to gain adequate weight ever since. At 11 months of age, the child presented to ER after the following course of events. The child had complaints of high-grade fever spikes for past 4 days, with a history of which was intermittent in nature, relieving with medications, and had intermittent dry cough at night for the past 4 days, which was insidious in onset and progressive in nature. On the day 2 of illness, the child developed fast breathing and increased work of breathing, for which the child was taken to a nearby hospital and was treated with nebulizers and later with inhalers. However, the child showed very minimal response to the nebulizers, and in view of worsening of symptoms, the child was admitted in ER. At ER, the child found to have fast breathing and distress and was started on oxygen support, IV broad spectrum antibiotic, and was admitted in level 1 PICU for monitoring. This was the X-ray taken at admission, which showed left lower lobe consolidation and right middle lobe consolidation. On further probing the history, there was no history of cough during or after feeding and regurgitation of feeds, which was not suggestive of GERD. No history of choking episode before the illness, which was not suggestive of foreign body. No history of recurrent respiratory tract infections or discharge. No history of abdominal distension, loose stools or blood in stools, or passing oily or bulky stools. No history of recurrent oral ulcers, oral thrush, or joint swelling. No history of decreased appetite or refusal to feed. No history of forehead sweating, suck cycles, or facial puffiness, sacral edema, or swelling of the limbs. No history of reactions following recent vaccination or blood transfusion. No history of bad child rearing practices. The past history was at 6 months of age, the child had similar complaints for which the child was admitted and treated with IV antibiotics for 5 days and nebulizations, but did not require oxygen support and was discharged home on day 5 of illness. At 9 months of age, the child was admitted again with similar complaints for 5 days, and the X-ray showed right middle lobe consolidation, and hence the child was treated with IV antibiotics but required PICU care for 3 days with oxygen support via nasal cannula. He was later discharged home on day 7 of illness with inhalers after the clinical resolution of symptoms. All the baseline investigations done were said to be normal by the mother. At 11 months of age, the child is currently admitted for pneumonia and was evaluated for recurrent pneumonia. There was history of home nebulizations and inhalers in the past with mild to moderate response to bronchodilators in between the illnesses. On reviewing the timeline of events, first admission at 6 months of age was treated as bronchopneumonia, and at 9 months of age, the child had second admission for recurrent right middle lobe pneumonia, and at 11 months of age, the child had both lower zone pneumonia for the current admission.
Thank you. We'll just stop you here just to analyze the history of present illness. Two ways we can analyze. One, and the third, current admission, you've seen the child. You see how the child developed fever, fast breathing, admitted in the ER, through the ER. And second is this, I think this is a third admission for pneumonia. So we have to analyze the causes. So two things we have to analyze. Analyze the cause for recurrent pneumonia, because the third admission for pneumonia within a span of 11 months. So how do you analyze the symptoms? Fever, cough, breathlessness. How are you going to analyze?
Usually cough followed by breathlessness.
After 2-3 days, child develop worsening of breathlessness and toxemia. What does it mean, Anirudh?
Maybe a viral infection followed by a bacterial infection, sir. Or it could be bacterial staphylococcal infection, which is getting complicated, sir, by empyema or pleural effusion, worsening pneumonia. Or it could be due to underlying wheeze, which is worsened by recurrent respiratory tract infection, sir.
The same child develops by 4th day reduced feed intake, irritability from fever, cough, and breathlessness. Does it mean anything new problem has shown up?
It can be a severe pneumonia, sir, or it can be due to hypoxia, and it can also tell us that the child may require PICU care or further monitoring, sir. Cough with difficulty in breathing can be due to under 5 wheeze or any upper airway obstruction like laryngomalacia or croup, or can be due to any other upper airway obstruction, sir.
As far as IMNC, once a child develops general symptoms, that means it is escalated to the next level of affecting the systemics, like neurology, like causing for acute encephalopathy because of hypoxia or toxemia. This our patient developed fever, cough, and by 3rd or 4th day, child developed breathlessness. Suppose the child developed cough, difficulty in breathing, same time without fever, what all the possibilities you will consider?
So it can be a recurrent wheezer, sir. The child can be a recurrent wheezer, or it can be due to acute cough, can be due to either foreign body obstruction, or it can be due to any other upper infections like ALTB or croupy cough, or it can be due to simple URI, sir.
And cardiac failure also can present, no? With or without fever, the child can present.
Yes, sir.
What are the various types of cough? Ilayaraja will take over from me.
So how do you classify cough, Anirudh? So basically, on what basis you classify and how do you classify cough?
It can be a wet cough or a dry cough, sir.
It's based on the nature
special
of cough. You are saying dry cough or wet cough. Otherwise, based on the duration, you can divide into acute, subacute, and chronic. Acute is anything lesser than 3 weeks is acute, and 3 to 8 weeks is subacute. More than 3 weeks is chronic. And acute cough, you always look for recognizable patterns. So, what are the recognizable patterns of cough? So, for example, for barking cough, where do you see, or in which condition do you come across barking?
The barking cough can be seen in ALTP, sir, and there can be croupy cough. Croup can be all other upper larynx and trachea.
Whenever there is a diffuse inflammation seen in the upper airway,
Yes.
larynx, trachea, and bronchi, so that is called croupy cough or the barking cough, right? So when do you get this staccato variety of cough? In which condition do you get staccato?
Pertussis, sir.
Staccato cough is usually seen in chlamydia, but it can also be seen in viral infections. How does it present? It presents with a series of
breath there will be
cough. Only difference is it does not have a whoop. If there is a presence of whoop, then it becomes
whooping cough.
Bouts of successive cough followed by a deep inspiratory whoop. That is seen in which condition?
The groups.
No, that is
whooping
seen in
cough.
I told you, no, there is a whooping cough. Pertussis. Okay.
Pertussis.
And a child who coughs predominantly in the daytime. At night time, the child is comfortable. Okay. So adolescent girl who is coughing badly in the morning, there's no lung signs. So there is no respiratory clinical examination is also normal. So can you think of which kind of cough will present like this? Only during daytime, nighttime completely normal. And has
mostly habitual cough, sir. Throat clearing.
The typical name that is given to is honking. Yeah, nocturnal cough you can divide into the most common cause is asthma, but you should also remember other conditions like postnasal drip and the ER. Typically, the asthmatic cough will present in the midnight or the early morning. So postnasal drip typically presents in the early morning, and GER can present after the child assumes the recumbent position. Okay, right. Yeah, now we finished the cough. Now coming to the next symptom, breathlessness. Breathlessness, you mainly want to differentiate between cardiac and respiratory causes. So can you tell me how do you differentiate based on history, based on examination? How do you differentiate between a cardiac cause for respiratory distress and a respiratory cause? Breathlessness, how do you differentiate based on the findings? On the history.
In the history, there can be a forehead sweating, or there can be edema. There can be other features of cardiac failure, sir. And in examination, there can be gallop or associated orthopnea or suck cycle, and there can be tachycardia and with murmurs, sir. In respiratory cough, is mostly because the breathlessness will be more severe with along with retraction, sir. While in cardiac cause, there will be only mostly effortless breath tachypnea can be there.
See, the main symptom is cough in case of respiratory diseases, whereas in cardiac diseases, the main symptom is breathlessness. Okay, all your PND, orthopnea, tachypnea, all these things, they present as respiratory distress. In respiratory conditions, there can be respiratory distress, but cough will be the most severe symptom. And in examination, you can find wheeze, crips, clubbing, all these things are very typical of a respiratory involvement. Whereas presence of edema, gallop, tachycardia, hepatomegaly, all these things are more in favor of a cardiac cause. So that is how you should differentiate between cardiac and the respiratory conditions. Okay.
In this, commonly we found it difficult to differentiate bronchiolitis from myocarditis. That's what common situation what we face in emergencies. A child comes with breathlessness. So closest DD for bronchiolitis is myocarditis. The child has disproportionate tachycardia, gallop or murmur, or lethargy, forehead sweating, hepatomegaly. This points more towards cardiac etiology like myocarditis. This will be very useful finding when we see a child in emergency.
Right. So in respiratory sounds, what are the audible respiratory sounds you know of, and what is the inference?
That can be
common respiratory sounds, audible respiratory sounds. What are the common audible respiratory sounds?
Can be stutter or stridor in case of upper airway sounds, sir. And there can be wheeze or crepitations or crackles or grunting that can more in the lower airway, sir. Snoring can also be seen in upper airway obstruction, sir.
Basically, snoring is a harsh, noisy breathing, okay, that is produced by the vibration of the upper airway muscles and upper airway structures. Basically, it causes partial airway obstruction. That is snoring. Stridor is a harsh inspiratory sound. That again is an upper airway obstruction sound. It can be either expiratory or inspiratory stridor also. Okay, expiratory means it is an intrathoracic obstruction, and inspiratory means it is an extrathoracic obstruction. These can be polyphonic or monophonic. These polyphonic means that that indicates there is a generalized involvement. Monophonic means there is a fixed obstruction somewhere, and usually it is seen in foreign body. And grunting is a typical moaning sound that is basically the force expression against close to glottis. It usually indicates an alveolar pathology or the lung pathology, right? Right. And stertor is
And our child, we didn't have any of this noisy breathing, I think. Is it not, Anirudh?
No, sir. Only minimal crepitations were there.
It is an auscultation. Okay.
Yes.
So when we'll consider viral etiology in respiratory infections, is it first of all common viral? Viral is common or bacterial is common?
Mostly viral etiology is common, sir, in
Across
very
all
young
ages,
children.
viral is most common. And when will you suspect viral etiology? Yeah.
So more than one system is involved when the child is not sick, not toxic looking, when there is multiple URI symptoms or multiple illnesses in the family, recent travel, and when there is more of URI symptoms, and when there is no toxic, complicated, when the X-ray shows bilateral infiltrates without severe complications like effusion or empyema, and investigations can they can have low CR. The inflammatory markers can be negative with the normal counts or mildly elevated counts.
Clinically, you suspect viral when the child is less toxic, active, okay, and multisystemic involvement. Usually they have a respiratory involvement and some GI involvement also. There will be diarrhea. There can be a respiratory involvement. In a child with bronchiolitis, they can have diarrhea. So usually multi-system involvement in an active child, less toxic child. So, and when the family members are affected, so that is the typical scenario when you suspect viral etiology, right?
Yes.
And any pneumonia, any child with pneumonia present with wheeze also, that is more in favor of a viral etiology.
Yes.
Okay, continue, Anirudh.
Coming to the antenatal history, the mother is conceived by spontaneous conception, and maternal age at conception was 29 years. The mother was booked and immunized, had 8 antenatal visits. Mother took iron and folic acid tablets regularly. The scans were normal. No history of fever during pregnancy. The antenatal period otherwise was uneventful. Next. Birth history: the child was born full term with normal vaginal delivery. The birth weight was 2.75 kg. Did not require NICU stay. Early breastfeeding was initiated with a child passed urine and meconium on day 1 of life. Umbilical cord has fallen on day 5 of life. There was no history of umbilical discharge or redness at birth. No history of oral thrush, pustules, or conjunctivitis.
Anirudh, can you explain why you specifically mentioned the umbilical cord fallen on day 5? Which problem you have it in your mind?
The delayed falling of umbilical cord can be a feature of this primary ciliary dyskinesia, or history of umbilical discharge can be due to neonatal sepsis, and which can indirectly lead to any features of inborn error of immunity.
Anirudh, you are a young lad, so leukocyte addition deficiency.
Yes, sir.
It is a situation where the umbilical cord will be delayed falling of the umbilical cord. So you suspect leukocyte addition deficiency, lad. Okay, proceed.
Family history: the child, this is the second born child of non-consanguineous union. The elder sibling is alive and thriving well. The mother is a known case of bronchial asthma on MDA use. There was no history of TB contact or early deaths in the family. There was no history of infertility in the family members. Nutritional history: the child was exclusively breastfed till 6 months of age. Now on direct breastfeeding and complementary feeding. There was no feeding difficulties. On rice-based semi-solid diet, 2 to 3 meals per day. Coming to the nutritional 24-hour recall, the calorie is recommended intake for this age of the child is 760 kilocalories. So the given intake is 620 kilocalories. The deficient is 140. And the protein intake is 12 grams per day, but the given intake is 9 grams per day. The deficit is 3 grams per day. Development and immunization. There was a mild delay in the gross motor development, where the developmental quotient is 72, and the child is immunized till 3.5 months of age according to national immunization schedule. The catch-up vaccination needs to be given.
Anirudh, you told that the child got slight delay in the gross motor milestone, which is expected in a chronic illness. Can you tell some more conditions where we'll expect selective motor delay? Selective gross motor delay will be seen in some more conditions. Can you mention few of them?
So there can be a gross motor delay in features of preterm and delivery, sir, and only gross motor delay can be seen in any other motor disorders like coordination disorders of cerebral ataxia and chronic respiratory
Rickets
infections.
is one of the common causes. Rickets.
Rickets.
Okay, wherever the hypertonia, rickets, spinal muscular atrophy. Okay, renal tubular acidosis, any child with hypokalemia, all these are reasons for selective motor delay. The higher mental function may be normal. Proceed.
Socioeconomic history. According to modified Kupasamy scale, the family belonged to lower middle class. No history of passive smoking, exposure to pets, birds, or indoor pollutants. No history of overcrowding or poor sanitation. Summary. This child is a 11-month-old male infant born of non-consanguineous union with complaints of acute onset fever, cough, and fast breathing, with a background of failure to gain weight, requiring 2 prior admission for respiratory tract infections, one being PICU stay, with smooth neonatal transition with mild motor delay. The provisional diagnosis for this child could be recurrent pneumonia, probably due to infectious cause. The differential diagnosis being
yes, child has presented with 3 episodes of pneumonia. Okay, but even during intervals, also the child has had wheezing episodes requiring nebulizations. Okay,
yes,
and mother is a known asthmatic.
Yes, sir.
So every time the child has required nebulizations, mother is also a known asthmatic. Can it be a wheeze associated respiratory infections, Valeries, or do you consider possibility of multi-trigger wheeze or a asthmatic child here?
Even though there can be a feature of asthma is associated lower respiratory tract infection, there is a radiological confirmation of pneumonia in this child, sir. And the child is also growth faltering, which is very unusual in a wheeze-associated LRI.
That is the main reason. Generally, even wheezers are they don't have any weight loss and failure to gain weight and the recurrent ICU admissions, requiring ICU admissions. So that is not very typical of a wheezer. That is more in line with a recurrent pneumonia. Right. Proceed.
The differential diagnosis for this child include congenital anomalies, inborn errors of immunity, GERD with aspiration, and severe acute malnutrition as an immunocompromised state.
See here, congenital anomalies means what? It is a broad.
Which system? Which system?
What type of congenital anomalies you are mentioning? Can you name some examples of congenital anomalies which can present as recurrent pneumonia?
So it could be simple laryngotracheomalacia, or it could be tracheoesophageal fistula, H-type fistula with recurrent aspirations, or it could be lung abscess, bronchial cyst, or it could be sequestration of the lung, or it could be not in this case, but generally congenital pneumonias with recurrent pneumonia, congenital anomalies with recurrent pneumonia can include a variety of lung deformities.
So all the laryngeal pathologies like laryngeal web,
cleft web,
fistulas, tracheoesophageal fistulas, even sequestration, pulmonary sequestration, CPAM, they can all present with recurrent pneumonias. So you have to mention as RV anomalies, congenital RV anomalies, not congenital anomalies. Right.
You didn't mention one of the rare but treatable condition like vascular ring. Vascular ring is one of the causes where they present more of stridor or wheeze with or without pneumonia with failure to thrive because it affects both the tubes, esophagus and trachea both are affected. So that is also one of the important cause. Difficult to prove by echo unless we do by CT angio.
Actually, in the history also, it included the history to rule out Malaysia. There are so many negative history you are telling. So now one history to rule out Malaysia is history of noisy breathing. Okay, that settles on prone position. That worsens on supine position and crying and feeding. Okay, so that is a simple history that can rule out Malaysia. So history-wise also that point can be included in children with recurrent pneumonia.
Okay, sir.
Sir,
Yes, sir.
SP sir, your comments, sir, any, they have come to the differential diagnosis.
Okay, before we go on to the physical examination, with the permission of Dr. Thangavelu, a few comments.
Yes, sir.
One, first, with Professor Srinivasan around, I think expected requirement of proteins of 12 grams for 11 months is too low. One comment, nutritional aspect. One, 11-month-old, it is, in fact, I remember my teacher telling us olden days, a 1-year-old child requires half as much calories and half as much proteins as I require. 20 grams protein and 1000 calories. That's a requirement of a 1-year-old child. 12 is very low, because you had mentioned that that is the requirement. A few points. Coming to the most important statements you made, you said that it could have been a 3 days illness. You said a viral infection giving rise to secondary bacterial infection. It doesn't happen in 3 days. So I want PGs listening to the session know that viral infection does not lead to pneumonia on day 3. Even bronchiolitis, it doesn't lead to bacterial pneumonia on day 3. It takes a longer time. There is usually a biphasic illness or a prolonged illness of viral illness, then going on to pneumonia. It doesn't happen like that. And coming to the differences between viral and bacterial infection, Thangavelu rightly pointed out, wheeze. Not only wheeze, if a child has a respiratory infection, in general, whether it is upper respiratory or lower respiratory, if the child or the infant has got a noisy breathing, the chances of the infection being bacterial are very, very low. In fact, easy to remember, viruses make much more noise than bacteria. Bacteria are very silent killers. Whereas viruses make a lot of noise. It's not only wheeze, even stridor, snoring, stutter, all are common only in viral infections, not common in bacterial infections, except perhaps grunt. And I was not sure, Anirudh, how the infant was between the 2 episodes of so-called pneumonia, which you think it is pneumonia, I'm not sure. 2 episodes of fever, cough, breathlessness, which we think it was pneumonia. And what happened to the infant? Was the infant completely normal in between those 2 episodes or not normal?
No, sir. The child required frequent nebulizations in between, sir.
What
But
needs
did
he?
not
No, let me tell you. Dr. Thangavelu, I'm sure, would agree. The Ilayaraja would also agree. Frequent nebulization is given to anybody and everybody with cough. Was there breathlessness? Were there chest retractions? Was there noisy breathing? In between those 2 episodes, if it had been given nebulization, it might be just for a trivial cough. That is very, very important. The reason why I am harping on that is that if it is a child who's not normal in between 2 episodes of pneumonia, is likely to have a systemic cause or a bilateral local cause, unlike an infant who's completely normal in between episodes. I hope you understood, Anirudh.
Yes, sir. That's
very, very important. That point you should have caught up. And more importantly, in the noisy breathing, Dr. Srinivasan would always appreciate that. Andrew Bush, in his article, he classifies the noisy breathing into snoring, snuffle, stridor, and then rattle. Rattle is a peculiar sound. In fact, I tell PGs, you hear rattle in the intensive care unit or in the intermediate care unit, where there will be children with cerebral palsy having respiratory distress. That rattle is a very peculiar noise because it is produced at the bifurcation of trachea. It doesn't resemble wheeze, it doesn't resemble stridor, it is very peculiar. It is because children who are neurologically impaired are not able to move the secretions well. So that is one type of noisy breathing. And you said that there had been some developmental delay. If there is developmental delay, particularly motor developmental delay, and if the mother had given you history that there had been breathlessness in between episodes of pneumonia, you could think of a respiratory problem triggered by a nervous system problem. That's another thing. And finally, recurrent pneumonia as a concept, you said radiologically it was there. Okay, that's accepted. When you have recurrent pneumonia, you should ask yourself the most important question if you want to identify the cause. The question is this pneumonia, which is recurrent, is unilobar or multilobar? Anirudh, what is it? Is it unilobar or multilobar?
Initially, first 2 episodes were unilobar, sir, right middle lobe consolidations.
Okay.
But the last episode was multilobar, sir, right middle lobe,
So
and also involving.
Yeah, it becomes multilobar. It becomes multilobar.
Yes,
why is that important? Can you answer the question? Why
unilobar consolidations? Unilobar
why
consolidations.
Why should you differentiate unilobar and multilobar pneumonia from history itself?
It can give a clue towards etiology, sir.
Excellent, excellent. In fact, to remember that, I usually tell my postgraduates, if there is a communal riot in Nungambakam, only everywhere it's peaceful, then it's a local problem. If there are communal riots from Kashmir to Kanyakumari, it's a national problem. On a similar note, if there is a unilobar pneumonia, it is much likely to be due to a local anatomical cause. On the other hand, if you have a multilobar pneumonia occurring at different sites, it is likely to be a systemic problem or a problem where the abnormality is in both sides of the lungs or in the airways. And finally, Dr. Thangavelu said vascular ring. Here again, in between these episodes of so-called pneumonia, whether there is any noisy breathing, even if it is trivial, that would have given a clue to the cause. These are my comments. Otherwise, excellent presentation, Anirudh. Thank you very much.
Thank you, sir.
Yes, sir.
Can we proceed? Yeah.
Yes, sir.
So now coming to the pneumonia stratification, see WHO has got a approved risk stratification criteria. So can you say what is the WHO definition for pneumonia? How is the risk stratified?
The WHO definition for pneumonia in children under 5 months to 5 years of age, sir. If there is a cough with fever with fast breathing and or chest indrawing, it can be considered as pneumonia, sir. And if there is a other features of warning signs like poor oral intake, severe stridor or persistent vomiting, lethargy, it can be considered as severe or very severe pneumonia, sir, based on the child status.
So all the symptoms, the most important sign that is classical of pneumonia is chest indrawing. Chest indrawing and simple fast breathing and chest indrawing will be classified as pneumonia with the presence of danger signs like poor feeding, lethargy, drowsiness, convulsions. All these things will make you suspect towards a very severe pneumonia, right? So with this, is it the same with IMC guidelines or is it different? How is it different, or is it the same with the WHO classification?
So in IMC classification, the chest indrawing from the pneumonia has been taken to a severe pneumonia. So there need not be a chest indrawing to diagnose pneumonia under IMC classification, sir. But the child must be calm while examination.
Severe pneumonia category.
Yes.
So fast breathing with or without chest indrawing is pneumonia as per WHO. If it is chest indrawing is there, it is as per IMC it falls under severe pneumonia. Why it is shifted there? Because IMC is basically for the tertiary health worker, so he has to refer the child urgently to the referral hospital. That is why the categorization is like that. Yes.
Anirudh, can you tell me some conditions where there will be only increased rate, but workup breathing is normal?
Sir, there
Why
can
it
be
is important to identify them?
to differentiate from respiratory and non-respiratory causes, sir. If the features of effortless tachypnea can be seen in metabolic acidosis and cardiac causes, or there can be fluid accumulation in the abdomen, like ascites, can cause effortless tachypnea, sir.
Very good. More commonly, even a fever can have a child come with a high fever and may have tachypnea. Once the fever settles, will come down. Very rarely, effortless tachypnea can also be a sign of neurological ICP, increased raised ICP, can also cause neurogenic hyperventilation. That also, if it is associated with altered consciousness. So mostly, it is good to look at the child. If there is no, it's called effortless tachypnea, can occur in serious conditions like diabetic ketoacidosis or even a neurological problem or other cause of metabolic acidosis. So what are the broad category of, because you said that the child had recurrent pneumonia, what are the broad category you can classify them in general? Because once you make a differential diagnosis, then you can identify and investigate on those lines to find out.
So as Sir said before, like it can be a localized cause or a generalized cause as a systemic cause. Sir. In localized causes, it can be differentiated into unilobar or multilobar recurrent pneumonia. Sir. And in unilobar, it can be due to foreign body mucus plug or isolated bronchial cyst obstruction, or it can be due to bronchomalacia, tracheoesophageal fistula, and general bilateral causes, and simple GERD with a recurrent aspiration. And then other anatomical causes like diaphragmatic hernia, sequestrated lung, and vascular ring can produce recurrent pneumonia. And immunodeficiency and congenital heart disease can produce recurrent pneumonia. Sir. And as recurrent under 5 years can also have a recurrent pneumonia.
So this is a simple way to remember. They come under this broad category. Recurrent aspiration may be GERD or TF, or in a child with cerebral palsy, maybe a palate of incompetence. Intrathoracic anatomical abnormality usually will have a localized pneumonia. It may not be affecting the multiple lobes. Functional abnormalities are cystic fibrous ciliary dysfunction. Immune deficiency generally will not be confined only to respiratory system. It can affect other skin and soft tissue, may have meningitis, liver abscess, lung abscess. All those conditions will be there in immune deficiency. It won't be confined only to respiratory system.
Yes.
So what are the warning signs to suspect primary immune deficiency?
Under the Jeffrey model, there can be recurrent pneumonia in either 2 episodes per year or 3 episodes in a lifetime.
Jeffrey model foundation may not be completely good for a clinician, but it is because it's meant for even non-medical people, social workers, everybody. So it's the JM Foundation warning signs are simple enough to be identified even by non-medical persons. That's how it is found to be very useful. Like in this child, we had pneumonia, growth faltering, need for IV antibody to clear the infection. So 3 things are there as warning signs. Second one is a spur. The spur is classically it's a simple mnemonic to explain a child presenting a severe infection, persistent infection, unusual infection, recurrent infection. This child had a severe pneumonia, recovering PICU care. Though it's persistent and recurrent, and unusual complication of pneumonia within 3 years. All these points towards probably we might be dealing with one of the inborn error of immunity, maybe one of the differential diagnosis to explain this recurrent pneumonia.
Okay.
Any clue from the age of onset of infection? What age the infection started in our child?
At around 6 months of age, sir.
Okay, that give you a clue for us to identify a type of problem.
Very early onset onset of recurrent infections can give a clue towards severe combined immunodeficiency, sir, or maternal transmission of HIV. And infection at around 4 to 6 months of age can give us a clue about B cell deficiency, where the child is protected by maternal antibodies till 6 months of age. And very late onset or adolescent or adult onset infections can give a clue about combined variable immunodeficiency or hyper IgE syndrome.
Of course, gross anatomical abnormalities like club palate, And then tracheostomy fistula also can present neonatal onset, but here we are discussing only in the immune deficiency conditions where based on the onset. In our child, what age started? 6 months, no?
Around 6 months of age, sir.
Okay. So to improve the summary further, so this doesn't look like a recurrent wheezer, even though child is put on preventers, doesn't look like wheezing, because associated failure to thrive and the demonstration of pneumonia. Doesn't look like cardiac failure because the symptoms, of course, you are going to examine the child. Doesn't look like a recurrent cardiac failure. There's no clear history of foreign body aspiration. Even the foreign body aspiration probably will be only confined to a localized one lobe, not affecting the other ones. No GI symptoms to suggest an associated cystic fibrosis, part of a cystic fibrosis. No ear discharge, which is commonly seen in ciliary function disorders. And again, pneumonia is the only infection which you have seen all the 3 times. It is not associated with other infections. So the possibilities are still maybe an inborn of immunity or primary immunodeficiency, even though there is no skin and soft tissue or organ abscess are demonstrated in this child. With this, I think probably Anirudh can go on to examination.
Yes. Coming to the general examination, the child is examined in the sitting position. The child was alert but tachypnic, pallor present, nasal flaring with chest indrawing was seen. No icterus, cyanosis, clubbing, lymphadenopathy or pedal edema was seen. The vitals were stable. BCG scar was noted on the left upper arm. Anthropometry, the child height, weight and head circumference all within 3rd centile, but head circumference was more than 3rd standard deviation. MUSE was 11 centimeter, which corresponds to severe acute malnutrition. Head-to-toe examination. AF was open, measuring 2 × 2 centimeter. There was no sparse or brittle hair, no eye discharge, no conjunctival xerosis, no bite-out spot, no facial dysmorphism or coarse facies, no low set ears, cleft palate or cleft lip noted, no angular cheilitis or stomatitis. Ear, there was no discharge or deformed ears or ear tags or sinuses. Coming to the nasal or oral, nasal and oral cavity examination, there was grade 1 tonsillitis, no oral thrush or supernumerary teeth found. Chest and trunk examination, there was no chest deformities, no kyphoscoliosis, no signs of rickets like rachitic rosary. Skin did not show any neurocutaneous markers, no skin lesions were noted, no eczema, warts or albinism was seen. Extremities were normal, genitalia was normal.
Okay, Anirudh, now in the general examination, you mentioned about bite-out spot. What is bite-out spot and what is the significance of bite-out spot?
So bite-out spot is a waxy triangular spot in the lateral side of the cornea. It is seen in vitamin A deficiency, mostly after measles infection.
And is it unilateral or bilateral?
It was most likely been bilateral.
Can be unilateral or bilateral. What is the common age group where you can see bite-out spots?
1.5 to 2 years.
Can be seen right from 6 months onwards, up to 6 years also you can see. And you remember this WHO classification for vitamin A deficiency? The XN is for blindness. X1A is conjunctival xerosis.
Conjunctival xerosis, corneal xerosis, bite-out spot, corneal xerosis, and corneal ulceration, keratomalacia less than 1/3 of the cornea, and keratomalacia more than 1/3 of the cornea, corneal scar, and xerophthalmic fundus.
Right. So when you look at the oral cavity, what is the importance of looking at the tonsils? Does it say something to you? Tonsils, when you see supernumerary teeth, or when you see albinism, eczema, what is the significance of each of these findings? Can it be associated with any particular disorder?
So absence of tonsils can give a clue towards Bruton's gamma globulinemia. And the supernumerary teeth can be retained primary dentition can be seen in hyper IgE syndrome, mostly after STAT3 mutations. And eczema can be seen in a variety of immunodeficiency associated with syndromes like Viscott-Aldrich syndrome. And partial albinism can be seen in Chediac-Kikashi syndrome.
Yeah. So if you see this picture, apart from this albinism, you can see the silvery gray hair in this Chidiac Higashi syndrome, and see the first picture, ulcer without pus formation. Okay. Second picture is there's a hypertrophied scar. So which condition will present like this? Ulcer without pus formation. So you can see in LADs, because it has where there will be ulceration, ulcer without pus formation. And you are also seeing the Omen syndrome, which is considered to be a variant of SCID, severe combined immunodeficiency. There will be extensive erythroderma. There can be alopecia also, skin scaling, and so all these problems are considered to be a marker of Omen syndrome, which is a variant of severe combined immunodeficiency. Right.
So these are only, we can't remember all this. You can just take a photograph, copy of it. It is various clinical signs which can be identified in general examination, which might give a clue for a rare disease like inborn error of immunity.
Coming to the respiratory examination, upper respiratory system, nasal septum normal, nasal flaring was noted, no noisy breathing, stridor, no drooling of saliva, no nasal polyps noted. Inspection, there was no apparent deviation of trachea on inspiration. Chest movements were bilaterally equal with respiration. Abdominal thoracic respiratory breathing was noted. Respiratory rate was 56 per minute, with the respiratory distress in the intercostal and subcostal retractions were seen. No scars, sinuses, dilated veins were seen on the chest wall.
Where will you see dilated veins in the chest? If you see a child who is breathless and also has dilated veins,
there is a superior mediastinal. Superior mediastinal syndrome, sir. Superior vena cava syndrome. Palpation. All the findings of inspection were confirmed on palpation. Apical impulse is palpated on the left fourth intercostal space in the midclavicular line. No intercostal tenderness was seen. No tracheal deviation. Bilateral equal expansion of the chest wall was noted. Percussion with limited examination. There was impaired percussion in the infraaxillary, interscapular, and infrascapular region. Auscultation with limited examination. There was a minimal diminished breath sounds in the infraaxillary, interscapular, and interscapular region, with occasional crepitations were heard.
So after examining the respiratory system and general examination finding, how do you localize the clinical signs? In general neurology, they used to say no upper motor neuron, lower motor neuron. So how do you categorize them? This is a very useful table. It partly starts with pulse and is given in most of the pulmonology, most of the medical books. See, it's also classified as upper airway disease, lower airway disease, parenchymal disease, and cardiac disease. In upper airway disease, usually the tachypnea relatively less. Like the rate may not be 70, 80, it will be only 30 to 40 because the obstruction causing prolongation of the respiratory phase. But severe retractions and stridor suppressed retractions means upper airway disease. Subcostal retractions, more of these lower airway disease. The child has got grunting. It indicates three problems, either maybe in the pulmonary parenchyma, pleura, or cardiac disease. In pleural disease, a stony dullness probably may be difficult to elicit in a young child. Will give a clue that it may be pleural effusion or empyema. The child has got tachycardia, gallop, and hepatomegaly. This may be a sign of a cardiogenic shock presently. So this table may be useful in an emergency to narrow down the possibilities to decide how emergently we have to manage the child. Go ahead.
Other system examination and CVS S1, S2 heard. No murmurs were heard. Apex beat heard in the fourth intercostal space in the midclavicular
Apex
line.
beat felt.
Yes, sir. Sorry, sir. Felt. And on the left side, abdomen soft, non-tender, no organomegaly. CNS, the child was crying, eye contact was present, or anterior fontanelle was lax, and moves all four limbs.
So remember the professors in ICH, whenever you feel the apical impulse, you have to feel with both the palms to not to miss dextrocardia. That will be a very good advice. We always follow even now.
Coming to the summary after examination, the master boy, 11-month-old male infant, second born to a non-consanguineous union, presented with recurrent respiratory tract infection and failure to gain weight for the past 5 months. And child was breastfed with complementary feeding. Anthropometry indicated severe acute malnutrition. On examination, he was afebrile, tachypnic, pale with crepitations, and decreased air entry was noted on the left side with no signs of respiratory failure. He also had mild motor delay with partial immunization given under national immunization schedule. Problem list include he had recurrent pneumonia with severe acute malnutrition with a background of Bs requiring frequent nebulizations. Possible differential diagnosis include inborn errors of immunity, possibly a B cell defect, and GERD with aspiration, and congenital airway anomalies.
So how are you going to plan your investigation based on this?
Investigations, so I would like to do baseline investigations like complete blood count and inflammatory markers like CRP and blood cultures to rule out acute infections now. And to rule out tuberculosis, I would like to do MAN2, chest, AFP smear, AFB culture, and a gene expert, and a chest X-ray. Barium swallow study can be done to rule out GERD and recurrent aspiration, and tracheoesophageal fistula, and ECG and to echo to rule out cardiac cause. HRCT chest to rule out other causes of bronchiectasis and chronic respiratory disease. Bronchoscopy to rule out a foreign body and other airway anomalies. HIV ELISA to rule out secondary immunodeficiency. NBT and DHR to rule out neutrophil function defects. IG profile and lymphocyte subset analysis to rule out primary immunodeficiency. Sweat chloride levels to rule out cystic fibrosis, and lastly, genetic study to rule out other syndromic manifestations.
The CT chest and bronchoscopy are very useful investigations in evaluation of recurrent pneumonia.
More yield.
So if the child has a unilobar pneumonia, which investigation will you choose? If the child has a bilateral or a multilobar pneumonia, which investigation will you choose among these two?
Mostly for a unilobar pneumonia, it can be mostly a localized cause. So I would like to go ahead with the HRCT test, rule out vascular ring and other causes of local obstruction, and followed by bronchoscopy, sir. And for multilobar pneumonia, I would like to rule out the systemic causes first. So I would go ahead with the blood investigations, sir.
Generally, in unilobar pneumonias, it is usually a local cause like a foreign body or a mucus plug. There, bronchoscopy will be more beneficial in identifying the particular pathology. Whereas multilobar consolidation, then you will have to find out whether it is going to be a systemic cause. So, what is the area of involvement? Then a CT may be useful, but as initial investigation for unilobar pneumonia, bronchoscopy is superior to a CT.
Okay.
Right. And one
also
more
pick
question.
up like condition like endobronchial tuberculosis. Also, it can pick up bronchoscopy.
Okay.
So another question is, let us say this child has got a dextrocardia, okay, and this child has also got a wet cough which requires nebulizations frequently. This child has already got nebulizations. Now, would you add up anything to a differential diagnosis?
I'd like to do a nasal nitric oxide test to rule out primary ciliary
first, yeah.
Primary ciliary dyskinesias or any ciliary dysfunction motility disorders.
Yeah. So the four things that you should always remember is, one is the neonatal onset respiratory distress. Number 2 is laterality defects. Number 3 is persistent wet cough. Number 4 is persistent upper respiratory symptoms like air discharge. Any two of these four are there, then you should suspect primary ciliary dyskinesia as one of your differential diagnosis, and you should proceed with the nasal nitric oxide and high-speed video microscopic studies. Right. See.
Investigation done in this child was the TB workup, which was done, was negative. Mycoplasma IgM was negative. HIV was negative. IG profile, all of the IG immunoglobulin levels were low, and other investigations are pending. Based on the above investigations done, the current diagnosis is a recurrent pneumonia secondary to primary immunodeficiency, probably a B cell defect. As the child is a male child, I would like to, it could be a Lick-Slick gamma globular pneumonia.
So can you interpret the radiographs?
This is a AP view of the chest X-ray, sir. The soft tissue is normal. There is no subcutaneous emphysema. The bony prominences, vertebra is normal, and the exposure is good. With there is no and there is a on the left side there is a right middle lobe consolidation with left lower lobe consolidation. There is a air bronchogram seen, so there is no the CP angle is not obliterated. So it is it is only a consolidation without any pleural effusion, sir. On the right side, there is a complete resolution of right middle lobe consolidation with partial resolution of left middle lobe consolidation. And the cardiac borders are also seen with minimal obscuration. And
so in the first X-ray, the left cardiac border is not clearly seen, or it
Not
is
clearly seen,
present with the pneumonia shadow. What is that sign called as? Is there any radiographic sign for the picture or the appearance? It's called silhouette sign.
Silhouette sign.
Yeah, so it is the
Masking
pneumonia.
of the borders, cardiac borders, diaphragmatic borders.
So based on that, you can
Okay,
localize the area lobe of the pneumonia. So the pneumonia shadow masks the cardiac border, so it is not very clearly seen. It is silhouetting the border. That is why it is called a silhouette sign. Right?
Okay, sir.
Yes. Next.
So coming to the management of this child, the child was started on O2 by non-rebreathing mask at 10 liters per minute in view of severe respiratory distress and tachypnea, which was later changed to nasal cannula as the child was maintaining saturation and the distress improved. And the child was admitted in level 1 PICU for monitoring. Baseline investigations revealed anemia, leukocytosis with severe neutropenia, and elevated inflammatory markers. X-ray showed right middle lobe consolidation and left lower lobe consolidation. Ultrasound chest showed minimal pleural collection of depth 3 mm. 2D echo was normal. Ultrasound abdomen for organomegaly was normal. Low flow oxygen was given for 3 days, and levosalbutamol nebulizations were given for 3 days, and IV antibiotics were given for 10 days. After which, with the above management, the child improved and was shifted to ward on day 5 of admission, and was hence later discharged on day 10 of admission. Currently, the child is
Anirudh, I ask one question. Can you define what is low flow oxygen and high flow oxygen?
Low flow oxygen is only by nasal cannula, which gives less than 5 around 2 to 3 peep, sir. The high flow nasal cannula can be used to give a peep of around 5 to 6, sir. It can be used in children with.
It is because of the more than inspiratory flow of the child is high flow. So the child may not need any entrapment of the air. Low flow means it has to be given oxygen along with this, something like a diluted milk. So low flow means it's taking oxygen less than the inspiratory flow of the child with the air. And high flow means it's only pure oxygen. Can you quote some condition where high flow oxygen is given?
Acute bronchiolitis, where the respiratory rate of the child needs to be reduced, sir. And
or in other words, I will ask you a question in a different way. What device will you use? High flow oxygen delivery devices. What are the high flow oxygen delivery devices? Like HFNC, high flow nasal cannula.
HFNC,
normally nasal cannula will give only up to 2 liters. Beyond that, it won't be useful, more irritating. A high flow nasal cannula up to 60 liters in adult or adolescent can be given. Second is any ventilated child.
Yes,
in NRM, which was NRM and head box was earlier classified as high flow devices. Now, mainly because it all depends on how much flow we give. So mainly it's a ventilated child. Second is the high flow nasal cannula. So these are the high flow devices.
Yes.
Okay.
Right. So we'll come to the next question. You can proceed with the management, then we'll take it from there.
Coming to the management plan, for acute management, the child needs should be given oxygen if required. Nutritional rehabilitation should be done. IV antibiotics should be started early in case of recurrent pneumonia. And specific treatment based on the etiology should be given with multidisciplinary care. And of course, chest physiotherapy will be helpful in clearing the secretions.
Right, Anirudh. So in pneumonias, you know that the pneumonia, there's other terminology that is used, it's complicated pneumonia. So how do you differentiate a pneumonia from the complicated pneumonia? Any clues clinically, radiologically?
There can be.
Before that, you see this video and tell me what it is. Okay. First video, what is it showing?
Ilayaraja, sound is audible, no?
Yes,
The child is grunting to create auto peep, sir, and it is a forceful expiration against a closed glottis so as to create enough pressure in
I
order
think
to.
Ilayaraja is asking about the first this video.
See, check whether it is inspiratory or expiratory. See the pattern of chest retraction. See whether it is in inspiratory or expiratory sound.
Inspiratory, sir.
So you can see the
How do you say, Anirudh? Inspiratory or expiratory?
Inspiratory, sir.
Sorry. Any sound which appears during retraction is inspiratory because retraction occurs only during inspiration. When you look at the video, see the sound occurs. The sound occurs during retractions. Here is external retraction, very obviously visible, is inspiratory sound. So stride is inspiratory sound only. Okay, shall I play the other one, Ilayaraja, or you want to ask more questions here?
Yeah, here, see, it's, the pattern of retractions, you are seeing sternal retractions. Suppose the same child has a suprasternal retraction. Okay, so what is the inference? Or when the child has sternal retractions, what is the inference? Now you agree that this is strider, isn't it?
Yes.
So strider with suprasternal retraction, strider with sternal retractions. Is there any difference?
The suprasternal retractions mostly due to upper airway obstruction, sir, like bronchiolitis or croup or
Bronchiolitis is not
ILTP, sir.
Bronchiolitis is a lower airway, bronchioles.
Yes,
this is a Malaysia, basically.
ALTB from Malaysia, yes, sir.
Suprasternal retractions you will see in laryngomalacia, whereas sternal retractions you will see in tracheomalacia. And you can see intercostal retractions, subcostal retractions in case of bronchomalacia. Okay, so Malaysia can present with this kind of retractions. If you are going to see sternal retractions with strider, then you should think of tracheomalacia, right?
Have you heard of biphasic strider, Anirudh? Sometimes strider need not be always inspiratory. It will also be inspiratory and expiratory, which is called a biphasic strider. What is the significance of, if you identify biphasic strider, what is the significance? It indicates intrathoracic upper air obstruction. Intrathoracic upper air obstruction. So normally glottic obstruction is extrathoracic upper air obstruction. If you see biphasic strider, it indicates the obstruction is below the level of the sternal angle. So intrathoracic upper air obstructions are like vascular ring, mediastinal mass, or subglottic stenosis. They present with biphasic strider. Shall I play the other video?
Yes, sir. Yes, sir. So this is grunting.
This is grunting, sir. Usually after along with the expiration, child is trying to maintain the peeps.
Okay, suppose we analyze the periodic Aspen triangle, what will say? Appearance, breathing, circulation. Look at the eyes. Look at the eyes. So upward gaze, probably seizures or acute encephalopathy. So it's in respiratory failure.
Yes, sir.
So what are the causes of grunting?
Why is the child grunting? Is there any pathology behind it? Why is the child grunting? Where is the pathology?
Mostly in the parenchyma, sir.
The child wants to maintain its own peep to keep the alveoli from collapsing. So what are the pathologies that can cause grunting in a child?
Severe life-threatening asthma or any airway collapse, sir, collapse consolidation like a foreign body, and
you tell common things, but pneumonia itself can cause
pneumonia. Severe pneumonia, severe complicated pneumonia can cause grunting.
And pleural disease like empyema or cardiogenic shock. All this can lead to grunting. Grunting is almost like an impending respiratory failure. If the child is grunting in the ER, you can't send the child for X-ray. The child will collapse on the way or in the X-ray room. So grunting is an impending respiratory failure. It has to be handled very, very safely.
Okay.
Can we move, Ilayaraja?
Yes, sir. Yes, sir. So now we were discussing about the clinical and radiologic clues of pneumonia versus complicated pneumonia. So first you tell me what are the clinical clues of pneumonia? Clinically, when you say pneumonia, apart from fever and fast breathing, what will be the findings?
In tachypnea can be there, sir, and associated tachycardia and chest indrawing, sir. And there can be, in case of severe pneumonia, there can be hypoxia or recurrent vomiting can be there. The child may be lethargic.
There can be grunting respiration, there can be
Grunting.
bronchial, there can be presence of either wheeze or crepitations. All these are physical findings. Air entry will be diminished.
Air entry will be decreased.
All these things are clinical pointers towards a pneumonia, right? Radiologically, so when will you call it as a complicated pneumonia?
If the child has associated pleural effusion, empyema, or if the child has
the first point is when the child fails to respond within 7 to 72 hours of treatment with antibiotics. We call it as complicated pneumonia. What are the radiological clues, or what are the clues towards when you start thinking towards complicated pneumonia? Is, as you said, parapneumonic effusion, empyema, or it can be a lung abscess, or necrotizing pneumonia, okay, or presence of bronchopleural fistula, or presence of general severe toxemia, sepsis, ARDS. All these things we will take into consideration that now it is a complicated pneumonia, including pneumatoceles. Or presence of all these things will make you think in terms of a complicated pneumonia, right?
Yes.
So can you interpret these two X-rays? These two X-rays, which is a simple pneumonia, which is a complicated pneumonia? Can you say based on these X-rays?
Yes, sir. On the left side, even though there is a patchy opacity seen in the right side, sir, but there are air bronchograms seen, and CP angle and the cardiophrenic angle is seen, and there is a the expansion will be normal in case of pneumonia, sir. And in the left side X-ray, there is a uniform opacity with volume expansion, and there is no air bronchogram seen, and the CP angle and the cardiophrenic angle is also obliterated, sir. And there is a minimal mediastinal shift towards the left side, sir.
So that is a very important finding. You can see the mediastinal shift towards the opposite side, indicating that there is a fluid accumulation. It can be effusion or it can be empyema. So this seems to be a complicated pneumonia, right?
So this picture tells you a story. It's an infant comes with features of pneumonia. You can see can you attempt quickly? I think running short of time. Anirudh, first X-ray.
The left upper lobe consolidation, sir.
Can you go more specific? Anything more like a round pneumonia?
Round pneumonia, sir.
Okay. Yes. Then second X-ray, you see some air pockets. It may be a resolution or worsening limatocele. This is the third picture. Fourth picture, child vomited blood-stained secretions and then developing the lung abscess. Necrotic pneumonia going for lung abscess. You can also see the osteomyelitis here. So blood culture has grown in MSSA.
Right. So X-ray wise, can you differentiate between viral, bacterial, or atypical pneumonia? Is there any specific pointers in the X-ray that can make you suspect towards these pathology?
Sir, in viral pneumonia, there can be bilateral patchy infiltrate, sir, with minimal ground glass opacities can be seen in HRCT, and the child may not be toxic looking, and there can be associated prodromal symptoms along with in the history of URI in the family. And in bacteria, the child can be toxic looking with a lobar or a segmental involvement, and there can be associated pneumatoceal pleural effusion or soft tissue involvement, skin and soft tissue involvement in case of staphylococcal infection.
See here, the typical description is a hyperinflation. Viral pneumonias, you generally have hyperinflation. Why do you get hyperinflation? Because of
viral associated wheeze can be there, sir.
Yeah. Why do you get air trapping? Because of mucus plugs. So viral pneumonias are known to cause outpouring of mucus. There will be a lot of mucus plugs that will be obstructing the peripheral airways. There will be always a hyperaeration. So bilateral hyperaeration with this typical picture of peribronchial cuffing. That is a classical picture that you will see in viral pneumonias. Bacterial pneumonias, it can be either lobar or a bronchopneumonia. Lobar pneumonia, it is confined to one particular lobe, or it can be a bronchopneumonia, where there will be a patchy involvement of multiple lobes. And the reticular nodular pattern is the area surrounding the alveoli. The interstitium will be affected, so that you can see in ILDs, in atypical pneumonias also you can see this pattern, right? So
Just skip this done. Okay.
this is the same thing I told. So even anatomically, you can classify as lobar or bronchopneumonia, basically based on single lobe involvement or multiple patchy opacities involving multiple lobes. And the interstitial pneumonia typically presents with the reticulonodular pattern in the chest X. So what are the common organisms that can cause pneumonia in children? Common organisms causing pneumonia. So how will you classify and how will you say that these are the common organisms?
Beyond the neonatal period, the most common organisms include viral pneumonia, sir, followed by pneumococcal pneumonia. And after that, there can be staphylococcal or atypical pneumonia.
Yeah.
And viral pneumonia, there can be RSV. RSV can cause common pneumonia, sir. And EBV and adenoviral pneumonia can be same, sir. And
rhinovirus, influenza virus, and adenovirus. These are other common viruses apart from human metapneumovirus also. All these things are common apart from the RSV. That is for viral pneumonias.
Yes.
Coming to bacterial, which is more common? What are the common bacterial agents that can cause pneumonia?
Bacterial, most commonly streptococcal pneumonia. If in an unimmunized child, Haemophilus influenza can be seen, sir. And staphylococcal pneumonia can also come along with skin and soft tissue infection. And in atypical pneumonia, mycoplasma can cause bacterial pneumonia.
Yeah, in immunocompromised children, you can get this Klebsiella and Pseudomonas. Okay.
Yes.
So that is the typical features. So what are the common drugs that can be used in community acquired pneumonia?
As OPD basis, if we are treating a uncomplicated pneumonia, most amoxicillin at 50 to 60 mg per kg per day can be given, sir, for 5 days, and followed by coamoxiclav as a second line of drug if the child is not responding.
Generally, the IAP guideline says that 40 to 50 milligram per kg is sufficient for outpatient therapy because the penicillin-resistant pneumococcal prevalence is lesser than 10%. That is for outpatient therapy. Okay. Yeah. So second line drugs.
Second line, we can give the child is not responding to amoxicillin. We can give amoxicillin with clavulanic acid, and we can also give cefuroxime. In case if we suspect atypical pneumonia where the child is not toxic, where the child did not show any features of pneumonia, we can add azithromycin, macrolide, or doxycycline.
And if staph is suspected?
When you suspect staph infection, because generally we can't isolate bacteria from respiratory patients.
Yes,
so when you suspect staph aureus, so that you will cover empirically.
If there is an associated skin and soft tissue infection, sir, if the child is toxic looking, and if there is a pneumatococcus in the X-ray, sir, and if there is a pleural effusion or an empyema, we should suspect a staph infection and cover for
rapid worsening, pneumatococcus, pleural fluid, necrotic pneumonia, and those situations. And some viral infections promote staph infections, like measles and influenza. They post-measles, post-influenza state, staphylococcal infection is common.
Okay.
Right. Inpatient therapy?
Inpatient, baseline, we can start with ceftriaxone or even cefotaxime, sir. Second line, we can go ahead with either BLBLIs or we can go with even augmentin, sir. And if Staphylococcus aureus is suspected, we can add cloxacillin or clindamycin, sir. And if the child is toxic looking with features of respiratory failure or systemic septic shock symptoms, we can go ahead with vancomycin.
So why do you want to give gentamicin or amikacin for less than 3 months category?
To cover for the gram-negative bacilli cover, like Klebsiella pneumoniae.
Lesser than any child more than 3 months, gram-negative infection is very less common. So in children lesser than 3 months only, you want to cover with aminoglycoside. Yes. So this we already covered post-measles, when you cover staph aureus. So now coming to the next question. So what is the percentage of under 5 mortality with regards to pneumonia? Is it common, less common? What is your take?
Beyond the neonatal period, pneumonia causes around 20 to 30% of mortality in under 5 children. So it is still a very much burden for the neonatal children under 5 years old. Sir.
If you take overall deaths, the prematurity and its complications still remain the topmost reason for under 5 deaths. But if you are excluding the neonatal period, then yes, the pneumonia may be the commonest cause for under 5 mortality. Right. So nowadays, last 2-3 years, we are seeing a surge in mycoplasma infections. So what are the scenarios, or what is the typical presentation of mycoplasma infections? When will you suspect mycoplasma?
Typical presentation of atypical pneumonia.
Correct. So when will you suspect, and how will you treat? So in a clinical scenario.
When there is a school going children from 2 to 5 year old child, who is
but it is not always like that. Even younger children can get, but it's generally common in older children. Yeah.
Then patchy opacities, and there is no non-sick
term
looking
is walking pneumonia. Walking pneumonia is not very sick. Even the X-ray, with the X-ray, you can say that there's significant lung involvement, but the child will be clinically very stable. So that is why it is called as walking pneumonia, right? Then,
if the child is not sick looking, sir, and if the radiological examination still shows a consolidation without any effusion, and if there is any extrapulmonary involvement like
consolidation
anemia,
is not the normal picture, but usually it will be a patchy involvement of the violent lung fields. But nowadays we are seeing both consolidation and, in fact, one case of empyema also we saw. So the mycoplasma, we don't know because it is of the resistant strain, but it is not the same. It's like patchy opacities. We can get consolidation, we can get effusion. All these things are possible with mycoplasma. So how do you
what are the extrapulmonary manifestations you were just telling started? Yes. Extrapulmonary manifestations.
So extrapulmonary manifestations of mycoplasma can include autoimmune hemolytic anemia, sir, and thrombotic conditions like thrombotic can occur, sir.
Skin rashes,
skin rash,
transaminitis. Transaminitis. It can also precipitate Stevens-Johnson syndrome. Okay.
Pericarditis and myocarditis can.
Okay, go ahead.
Now, how do you investigate for mycoplasma?
So, serial titers of mycoplasma IgG can be seen, sir. Mycoplasma IgM and mycoplasma PCR can give a closer. And treating mycoplasma, we can usually start with macrolides. If it's not responding, we can go ahead with doxycycline. And in rare cases, we can include levofloxacin, sir, in case of severe infection.
Yeah, so TB is a common problem in our country. So TB, what are the usual lung picture? What is the chest X-ray pictures that you can have in tuberculosis? What are the different presentations, radiological presentations of tuberculosis?
Usually, hilar lymphadenopathy is the most common involvement of tuberculosis in younger children. So, there can also be primary parenchymal involvement with primary focus and primary complex.
What is the focus called as?
The primary
focus is called as Gaunt's focus. Yeah. Then.
And there can be cavitation, sir. And in case of miliary TB, there can be miliary modeling.
Cavitation you generally don't see in smaller kids because it is a condition that presents chronic illness. So usually cavitation is in adolescents only, and usually they present with hemoptysis. Again, pleural effusion also, it is not common in younger children. Usually older children, adolescents, they present with pleural effusion. And miliary TB is one unmistakable finding which you see in immunocompromised children with tuberculosis. Right. So BCG, now that we are seeing a child with immunodeficiency, what will be the BCG changes in a child with immunodeficiency? Because at birth, you don't know whether the child has got immunodeficiency or not. So you are given BCG. So what are the BCG reactions that are likely to develop following a BCG vaccination in an immunocompromised child?
There can be local reactions like BCG iadenitis or BCG abscesses, or there can be systemic involvement of miliary TB, miliary pattern in lungs, and enlarged lymphadenopathy in the mediastinum, or there can be lytic bone lesions that can be seen, sir, and there can be bone marrow involvement also can be seen, sir.
So which condition you will see local reactions, which condition you will see severe reaction, BCG, severe disease, severe BCG disease.
In the milder forms of neutrophil function defect like chronic granulomatous disease or Mendelian susceptible for mitochondrial diseases. And in case of severe diseases like SCID and IFN, interferon gamma receptor deficiency, we can see the disseminated BCG disease.
Right.
SPS sir and Prasanna, how much time we can take? I think we come to the end. Another 10 minutes. Allowed?
Yes, sir. Sure, sir. You
Okay.
can.
Okay, I'll go faster then. So if you think of primary immune deficiency or inborn immunity, what are the various types? And many will not investigate for inborn immunity. Have you seen this picture? One of the rare book called Nelson. Very nice picture. I'm happy to explain this. 4 types: B cell defect, D cell defect, phagocytes, and complements. So B cell defects mostly recurrent cyanobacterial infections, bronchiectasis, recurrent diarrhea. So immunoglobulin profile and lymphocyte flow cytometry. T cell usually failure to thrive, severe viral infections, pneumocystis carinii, lymphocyte count and flow cytometry, T cell proliferation. Phagocytic defects usually present the abscess, adenitis, severe bacterial infection, poor wound healing, periodontal disease. There are 2 tests for that: NBT, the nitrobutyl tetrasodium test, which has got observed variability. So that's why now more preferred is dihydrorhodamine test, because recently we had a negative NBT for a child who was genetically proved as chronic granulomatous disease. Complement deficiency, mostly they present like in autoimmune disorders, like early onset lupus, a 1-year-old child with lupus, or Neisseria infections, CH50 and AH50. These are the basic tests. And this box tells, I'm happy to say that the basic understanding for a general pediatrician will be very useful. Now, IGP, I think 2021, there is a separate issue on immunology, which is very simple for us to understand. Nowadays, the subjects are very, very difficult for us to understand. It has given 10 types of classification inborn immunity. First, 1, 2, 3 is combined immunodeficiency, both cellular and human immunodeficiency, and with syndromes. Third is predominantly antibody deficiency. So the first 2 quarters, 1, 2, 3 occupies this. Then comes congenital defects of phagocyte numbers of function, and intrinsic and innate immunity is 5 and 6 here. This side, phagocyte side. Complement is on the 8th side. So mostly syndromic features. Some of the children with immune deficiency has got syndromic appearance, like eczema, thrombocytopenia, viscodolitic syndrome, metaxotelangiectasia, Dijar syndrome, with abnormal faces and hypocalcemia, hyper IgE, all syndromic features of primary immune deficiency. But at the same time, smaller, milder, many mothers used to come to my papa immunity illa, adikadi maskla or cold cough vandirudhu. So these are all recurrent UREs, mostly in school going children. They are self-limiting, they don't get admitted. Most of this does not come under the primary immune disorders. It has to be only without weight loss, without getting admitted. They're self-limiting, without 3 to 5 days, they settle. All these are does not need any investigations. Some situation, recurrent infection confined to a single site, single anatomical site, like HT fistula or TF or retained foreign body. Those situations also may not need any extensive investigations. Of course, secondary immune deficiency, I'll just skip it for the sake of time. Do you think the basic lab tests are useful for diagnosis? You said for your child also you start with CBC. Do you do it routinely, or CBC really does some help for immune deficiency?
Definitely,
Or
sir.
routinely start with CBC.
It does give a clue on what next investigation that needs to be planned, sir. And any investigation we send needs to be history backed by history examination and clinical findings, sir.
Sometimes CBC tells something more than, for example, persistent neutropenia. Neutropenia means absolute neutrophil count less than 1,500, can occur in cyclical neutropenia, Swachman-Diamond syndrome, and severe congenital neutropenia, can present with absolute neutrophil count of 1,500. Persistent neutrophilia usually suggests a child with infection, even after the infection subsided, persistent high neutrophil count can occur in LAD, and high WBC count, 30,000, 40,000 counts, can occur in chronic granulomatous disease. And most of the time we miss lymphocyte counts. So if there is a lymphopenia, thrombocytopenia, how is going to be helpful? Usually in young child, less than 5 years, usually there is a lymphocytic predominance. If you see a child with the absolute lymphocyte count of less than 3,000 general number, but the count has to be modified according to the age and the total count. Any child with persistent lymphopenia less than 3,000 per cubic millimeter, you should strongly suspect that it could be SCID. Thrombocytopenia, we already seen thrombocytopenia, eczema with immune deficiency, maybe Viscard-Daley syndrome. More than just a screening test, they really point out to a specific diseases from very early. Once after doing all the investigations and even the genetic tests, when you go back, CBC says, and CBC will give us a clue. SCID, I'll also skip this. The child usually present with infections very early. And recently, one of our postgraduate, he shared his patient's details. A 3-month-old baby came with seizures, posturing, birth neonatal period uneventful, even attained social smell, tachycardia, tachypnea, shock. And then the WBC count was 5,820, polymorph 81, L 10.7. Do you comment about this? Can you comment about this, Anirudh?
The absence of thymus along with associated with lymphopenia and a low IG profile can give us a clue towards severe combined immunodeficiencies.
Okay, look at the X-ray and pick up very important finding. And the picture on the right side is the patient.
The arrow mark is pointing towards
absence of thymus, sir.
Oh, that's very, very important finding. No? Absent thymus is a very, very important finding. Any upper mediastinal shadow less than 18 months, unless proved otherwise in a thymic shadow in a well child. Here, a sick child doesn't have thymus at the age of 3 months. It's a very, very important pointer. And then he did further immunoglobulin profile. It was found to be low. That is SCID. And then he referred this child to a tertiary care center. So, I just quickly sum up. When you do immunoglobulin profile, high IgM, hyper IgM, high IgE, hyper IgE. If the M and E are low, M and G are low, and B cells are absent in the flow cytometry, it is A gamma globulinemia, X-linked recessive. And IgM and IgE and G are low, but B cells are normal, means it can occur in common variable immune deficiency. In a child with recurrent pneumonia, when we suspect CGD, but I don't want to go through the detail completely. Unusual pathogens like Aspergillus, gram-negative bacteria, Burkholderia, Acinetobacter, Cenotrophomonas, suspect. A child with recurrent pneumonia, cutaneous infections, sinuses, partly healed ulcers, abscess, osteomyelitis. So think about CGD. This X-ray shows a very nice, I can't say nice, very important essential feature which we can't miss. The child present with recurrent pneumonia, and when you look at X-ray, I just, for want of time, I will start explaining. This is a dot there. When you are given only the first X-ray, you may even think that it may be an artifact. The quality of the X-ray is poor because a lot of artifacts are there. Look at X-ray, day 1, day 50, and day 20. The yellow arrow completely points to the single dot. 2 black arrows, these 2 dots are above the diaphragm as persisting. And anything else persists beyond the lungs? Anirudh.
red arrow.
Red arrow.
Subcutaneous granuloma can be.
What do you think? Can you explain that?
Subcutaneous granuloma can be seen in CGD, sir, chronic granulomatous diseases.
So this is probably a calcified lymph node. So 3 conditions may be DD for this: tuberculosis, sarcoidosis, and chronic granulomatous disease. So DHR is more specific than NBT. So last question: for every disease nowadays, newborn screening is available. Do you think newborn screening will be useful in picking up at least kid? Because nowadays we have treatment. Earlier days, no, it is only for the sake of making a diagnosis. If you make a diagnosis, there are a lot of, everybody will come for help. Hematology will come for help. So everybody is willing to come for help and save the child. So do you think newborn screening will find out immune deficiency?
There is a new T cell receptor.
It's called excision circles. Probably this can identify screening. Definitely, even the heel stick, I think I have not personally experienced. Book says that, and even the heel stick can identify this TRECs, T cell receptor excision circles, the marker of T cell development. If they point to that, probably the child immediately will be, without wasting much time, one of the books says that skid diagnosis is emergency. So shift the child before the child catches a severe infection, and probably BMT will give a complete relief for this. Thank you, Anirudh. Thank you. You presented well. You answered the questions well. Thank you very much, Prasanna and SBS sir. SBS sir, for your additional comments and for time. Thanks so much, Naram, Prasanna and SBS sir. Srinivasan sir. Thank you all. Sir,
Thank you so much for
SBS sir,
giving
any
this
more comments?
Prasanna, do you have time? Do you have time for comments, or
Yes,
we'll wind up?
you can do, sir.
Sir, definitely, sir. We need your comments.
60
Okay,
people there
okay. Yeah. In fact, I'm always a student first. I try to learn from every
I
case.
need to answer. Yeah, and share.
Yeah, thank you. Brilliant discussion. Few comments for improvement for postgraduates. One, you had mentioned in the physical findings decreased breath sounds with crackles. What does it mean? I think there is something wrong somewhere, because in pneumonia you don't get decreased breath sounds. Decreased breath sounds indicates volume loss. It occurs only when there is collapse. But the X-ray shows definite air bronchogram. If you see the X-ray indicating that there is pneumonia, I would have checked the breath sounds once more rather than say it is decreased breath sounds. It doesn't happen in pneumonic consolidation. One. Second, you had mentioned ESR and urine culture for this child, and also Manto. These three tests I wouldn't do at all. Manto nowadays, even the RNTCP discourages use of Manto. Students here must know the Manto is going to be replaced by CTB test manufactured by Serum Institute of India. The government is going to implement wide availability, which is better than Manto and as good as probably IGRA. Urine culture for this child is not rational. You have pneumonia. What's the point in doing urine culture? And UTI is not a symptom of immunodeficiency. So don't worry about urine culture. And in addition to what Ilayaraja mentioned, neonatal onset of cough and persistent cough is a very important clue to primary ciliary dyskinesia, in addition to ear discharge, recurrent ear infection. You can't diagnose PCD without otitis media. It's very frequent. And of course, 11-month-old baby, please don't waste your money by doing mycoplasma IgM. Particularly in a child with immunodeficiency, you don't worry about mycoplasma. IgM is a useless test. And I was wondering why levosalbutamol in an infant who doesn't have wheeze. That's what I said. Anybody with cough today is treated with salbutamol and budesonide, whether it is wheeze or not. And the other comments are, any child who has got pneumotocele, the tendency of the pediatrician is always blame Staphylococcus. In fact, if you look at studies both in India and abroad, pneumotoceles are most often due to pneumococcus more than Staphylococcus. Necrotizing pneumonia is more often due to pneumococcus than Staphylococcus. So the commonest cause for pneumotocele is not staph, is pneumococcus followed by staph aureus, and other organisms like H. flu, Klebsiella, Streptococcus, and tuberculosis can cause pneumotocele. Klebsiella is notorious to cause pneumotocele with a bulging interlobar fissure. Bulging fissure. And in the treatment algorithm, you had put ceftriaxone plus cloxacillin. I know it is there in the IAP guidelines. If you use ceftriaxone, cloxacillin is redundant. Don't give both. Okay, ceftriaxone is as good as cloxacillin for MSSA. It won't work for MRSA. So the combination of ceftriaxone or cefotaxime with cloxacillin Like the earlier combination, Dr. Thangavelu would be familiar, the 20 years back, ampicillin, cloxacillin, another unscientific, irrational combination. So ceftriaxone, cloxacillin is an irrational combination. Don't
Prior
use.
to that, we used the streptopenicillin. Remember? Streptopenicillin.
Yes. And then erythrochloro-OP. Then, and in staphylococcal pneumonia, you had mentioned vancomycin. Vancomycin is inferior to teicoplanin for staphylococcal pneumonia. Teicoplanin is better because of higher lung concentration. And the new terminology PGs should know is called MIRM, mycoplasma-induced rash with mucositis. Dr. Thangavelu very nicely mentioned about the extrapulmonary manifestations. And last comment is the immunodeficiency screening is being implemented in many Western countries. In fact, in the NHS UK, they are doing neonatal screening tests and they are giving BCG only at 28 or 30 days after the reports come negative. Dr. Thangavelu very clearly said your SCID is an emergency. In fact, many of the SCIDs die of tuberculosis, that is BCG-induced tuberculosis or CMV. They don't die of immunodeficiency, they die of tuberculosis or tuberculosis, anti-tuberculosis drugs and side effects and various combinations. So in the UK, they do not give BCG in the early newborn period. They give it only at 28 or 30 days after the immunodeficiency reports come. Then only they give if the reports are negative. I am sure it's going to happen in India in the next 10 to 15 years, like thyroid screening, we are going to definitely have neonatal screening. In the New York City, I believe the neonatal screening for immunodeficiency regularly happens. These are my rather long comments. Excellent presentation, Anirudh, and brilliant inputs from Dr. Thangavelu and Dr. Ilayaraja. Hats off to both of you. I learned a lot. Thank you very much.
Thank you very much. Thank you, sir. Thanks for your important pearls at the end of the discussion, whatever left out. Thank you so much, sir.
Thank you, sir. Actually, I wanted to tell all the PGs the lesson that you should learn is how SPS sir and Thangavelu sir puts their effort in these analysis and discussion. I don't know whether Anirudh would have did so much of effort, but Thangavelu sir for the past 1 week Anirudh, I know how much Anirudh slides and how much Thangavelu sir slides in this. So to impart that knowledge, we asked for one case and that case. Sir has asked so many ASCIIs in this.
Okay, I'll call you.
If somebody has seen this entire this thing, they would have got at least 10 to 15 ASCIIs also in this. Apart from one PG case, there are 10 to 15 ASCIIs in this discussion. So we had a very good number, sir, today. 75 at the maximum joined, and YouTube 20-25 people have joined. So
Prasanna, we didn't study well when we were all very young. That is why now we are studying.
I don't know. This is one learning point for us. It is Somasundaram, sir. Yes, sir.
Yeah, so excellent, sir. Excellent session today. And as Prasanna mentioned, so usually the faculties will be giving their inputs, but sir has taken efforts in giving his slides, and as a panel discussion is going on, so sir has given the names of ER, ST, and Anirudh. So excellent, sir. So it was a very useful session, and many PGs must have benefited today. I can see on the participant list, and about 20 were on YouTube also. So it was an excellent session with more and more picturesque and live videos from Ilayaraja. So thank you the faculties today, Dr. Thangavelu sir and Ilayaraja, for your time in presentation and for the efforts you have taken to make this presentation more colorful and flavorful. And as usual, SPS sir, thanks a lot for your presence today, sparing your sixth month also with us. We have another 6 more months, sir. We'll make it more interesting in the few days with your presence also. And your comments at the end has struck everyone's mind, and I too take it at the right sense, sir. Thank you very much. And finally, my heartfelt thanks to Prasanna for his efforts, and he continues to pick up the right faculty for the right topics, and the coordination he does for the whole month is excellent. Thank you, Dr. Prasanna.
Anirudh should try for gold medal, Somasundaram. Anirudh should try for gold medal. All the best.
Thank you so much, sir. At this juncture, I want to thank.
Somasundaram sir, Dr. Prasanna, I thank the IAP CCB team for giving me this wonderful opportunity to be a faculty for the case presentation along with my teachers, SBS sir and Thangvel sir. I have been a PG. I have attended classes with both of them. It's a great honor for me to be a faculty along with them. Thank you for giving me this wonderful opportunity for both Dr. Somasundaram as well as Dr. Prasanna. Thank you.
There are many teachers also who have logged in this forum. Dr. Nipetita, Dr. PRC sir, Dr. Janani madam, Dr. Srinivasan, and I could see Dr. Meera Jaishankar. Many people, many senior pediatricians and teachers were also there to listen to stalwarts. So such an excellent session, sir. Thank you very much, every one of you, for sparing your evening OPD and be with us on this Tuesday evening. Thank you very much.
Sir, one more message, sir. These videos are recorded and uploaded in IAP CCB channel. Those who have missed or those who asked for a link, you can please share them. All the PGs, those PGs who are on duties, so you can please ask them to view these videos again. It is available on IAP CCB channel. So with this, we'll come to an end. Thank you so much, sir. We'll meet for the next session in last week of Tuesday of July month. Thank you, everybody.
Thank you.
Thank you.
This juncture, only one, sir. I would like to express my thanks to all Janani madam, who made me, who encouraged me to present in this forum, and I would like to thank Thangavelu sir and Ilayaraja sir for constantly supporting me through this journey, sir. And I would like to thank give my sincere thanks to Balasubramaniam sir, who has been great inspiration to enter into this profession, sir. Thank you. Thank you so much, sir.
Thank you.
Thank you.
Thanks,
Yeah.
Thank you. Ending the meeting for all.